Welcome to This Week in Allergy and Immunology. This week we're covering 10 notable papers spanning health disparities in food allergy and asthma, molecular and cellular diagnostics in food and drug allergy, and management questions in upper and lower airway disease. Let's dive in. We'll start with two papers arguing that social factors are not background noise, but measurable drivers of allergic disease biology. In the Annals of Allergy, Asthma, and Immunology, investigators from the Forward Cohort looked at nearly 1,400 children under 12 with physician-diagnosed IgE-mediated food allergy and asked which children had already outgrown at least one of their allergies. The pattern of resolution was largely as expected. About a third of children had outgrown milk or soy, roughly a quarter had outgrown wheat, while resolution of peanut and shellfish allergy was reported in fewer than 4% of children. What is harder to explain away is who had outgrown their allergies. White children reported resolution more often than Black and Hispanic children across all common allergens, and children without reported resolution came from families with lower income, lower parental health literacy scores, and higher area deprivation indices. This is a cross-sectional caregiver-reported analysis at enrollment, so we cannot separate true immunologic persistence from unequal access to oral food challenges and follow-up. And that ambiguity is itself the clinical message. If your practice is not proactively reevaluating and offering challenges to families with fewer resources, some of those children are carrying diagnoses they may have outgrown years ago. The companion paper in the Journal of Allergy and Clinical Immunology in Practice comes from a bronchoscopy-based cohort of over 400 children with severe treatment-refractory asthma. Children classified as type 2 high, meaning blood or lavage eosinophilia plus specific IgE, were compared with type 2 low children. The type 2 high phenotype was already dominant by age 5, and in multivariable models, self-reported Black race carried the highest odds of type 2 high inflammation, roughly threefold, even after adjustment for household income and other social and environmental factors, with similar results from neural network models. The authors' framing is that race, adjusted for disparities, is the principal determinant. The more cautious reading is that residual unmeasured exposures track with race in ways income alone does not capture. Either way, for a young Black child with severe asthma, the prior probability of type 2 inflammation is high enough that early phenotyping and consideration of type 2 targeted biologics deserves emphasis. Our second theme is diagnostics that go beyond whole extract testing. In allergy, an Italian tertiary care cohort of 114 patients with hazelnut or walnut allergy profiled individual seed storage proteins, including newly available visilins. Severe reactions were more common in hazelnut than walnut allergy, roughly 43% versus 24%. Among hazelnut components, Cor14, Cora9, and the type 2 visilin Cora16 showed severity gradients, with Cora16 giving the best discrimination for severe reactions at an area under the curve of about 0.72, modest. For walnut, JUG-R1 performed considerably better, with an area under the curve near 0.9. After adjustment for age and sex, Cora14, JUG-R1, and JUG-R2 remained associated with severe reactions, and the two type 2 visilins were the strongest co-sensitization pair. This is single-center, tertiary, and needs external validation, but it supports component-resolved testing rather than extract alone when you are stratifying nut-allergic patients for risk. A parallel geographic story appears in Allergology International, comparing Thai and Austrian adults with banana allergy. Systemic reactions dominated in Thailand, over 90% of the Thai patients, while isolated oral allergy syndrome accounted for close to half of the Austrian patients. Banana extract-specific IgE was positive in only about 70% of sera in both countries, and among sera with undetectable extract IgE, molecular testing found relevant reactivity in nearly all cases. Thai patients were overwhelmingly sensitized to the thaumatin-like protein MuSA4 at 90% versus 46% in Austria, and in the Austrian cohort, thaumatin-like protein sensitization was independently associated with systemic reactions and greater severity. The TI estimates were imprecise precisely because that sensitization was near universal. The practical point is that a negative banana extract IgE does not exclude banana allergy, and sensitization profiles are not transportable across populations. Staying with diagnostics, the Journal of Allergy and Clinical Immunology in Practice reports a retrospective cohort of 223 patients with severe cutaneous adverse reactions and other non-immediate drug hypersensitivity, comprising 450 drug-level interferon gamma ELISpot tests. Adding anti-PD-L1 to the assay raised positivity from about 14% to about 35%, an absolute gain of roughly 21 percentage points. Conventional positivity was numerically lower in corticosteroid-treated patients, and that gap disappeared with PD-L1 blockade. Reassuringly, positivity remained confined to a single culprit drug in most patients tested against several drugs, so specificity does not appear to collapse. This is retrospective, single-center, and the augmentation was applied selectively rather than randomly, so prospective validation is needed before it changes routine practice. But for the patient on steroids with a remote DRESS episode and multiple candidate culprits, this is the direction of travel. Our third theme is management, and here the chronic rhinosinusitis papers are the most interesting because they sit in tension. In the Journal of Allergy and Clinical Immunology, investigators profiled 69 inflammatory mediators in nasal polyp tissue from 91 patients dichotomized into rapid recurrence within a year of sinus surgery versus no recurrence beyond 2 years. 23 mediators predicted rapid recurrence, and they split into a familiar type 2 group, interleukin-4, interleukin-13, interleukin-5 receptor alpha, eosinophil cationic protein, IgE, and an innate myeloid group, including multiple CC chemokines, GM-CSF, interleukin-1 beta, interleukin-6, MMP12, and HIF-1 alpha. In a separate prospective cohort starting dupilumab, the drug reduced interleukin-5 receptor alpha and several chemokines, but left the key myeloid mediators untouched. That persisting parallel axis is a plausible explanation for why some patients relapse, and a candidate target set for the next generation of therapy. Alongside it, a clinical perspective in the Journal of Allergy and Clinical Immunology in Practice tackles perioperative biologic use around sinus surgery, and concludes, bluntly, that the evidence is sparse, heterogeneous, and inadequate to support firm sequencing recommendations. Dupilumab has the most perioperative human data with no clear operative harm signal. Omalizumab and mepolizumab have supportive but incomplete evidence. Tezepelumab and dupilumab have essentially none. Standard care with topical intranasal corticosteroids and saline remains the baseline, and neither routine interruption of biologics nor default postoperative initiation for everyone can be justified. 2 more pragmatic papers round out the week. A systematic review and meta-analysis in the Journal of Allergy and Clinical Immunology in Practice pooled 16 randomized trials of pulmonary rehabilitation, combining education and exercise training in adults with mostly moderate to severe asthma. Rehabilitation improved asthma control, exercise capacity, quality of life, anxiety, and depression, but showed no significant effect on lung function, airway inflammation, physical activity levels, or body composition. And most trials carried high risk of bias with very low certainty for some outcomes. So it is a reasonable adjunct for symptom burden and function, not a physiologic remedy. And in the International Archives of Allergy and Immunology, a meta-analysis of 6 studies and just over 900 patients with allergic rhinitis found a pooled prevalence of objective eustachian tube or middle ear dysfunction of about 36%, with individual estimates ranging from 18 to nearly 50%, and substantial heterogeneity driven largely by how dysfunction was defined. The base of evidence is small and geographically narrow, so the authors support selective rather than routine tympanometry in patients with persistent obstruction, hearing complaints, or recurrent effusion-like episodes. Finally, in allergy, a Krakow study of 50 birch allergic patients and 25 controls over 2 pollen seasons found that pollen collected from highly polluted sites produced significantly stronger basophil activation than pollen from cleaner areas, and asthma symptoms correlated with both pollen and particulate matter concentrations. A mechanistic argument for reading pollution and pollen counts together when you counsel patients. If you only have time for one paper this week, make it the forward analysis of food allergy resolution in the Annals of Allergy, Asthma, and Immunology. It reframes outgrowing food allergy as something that depends partly on who gets reevaluated, which is a lever every one of us controls in clinic next week. Here are the key takeaways from this week in Allergy and Immunology. First, milk, soy, and wheat allergies resolve in roughly a third of children, while peanut and shellfish rarely do, but reported resolution tracks with income, health literacy, and neighborhood deprivation, so actively schedule reevaluation for under-resourced families. Second, in severe childhood asthma, Black race carried about threefold odds of type 2 high inflammation even after adjusting for social and environmental factors, and the phenotype is established by age 5, favoring early phenotyping. Third, component resolve testing adds real information in nut and banana allergy. JUG R1 discriminated severe walnut reactions well, and molecular testing found reactivity in patients with negative banana extract IgE. Fourth, adding anti-PDL1 to the interferon gamma ELISpot roughly doubled detection of culprit drugs in non-immediate hypersensitivity, including in steroid-treated patients, though prospective validation is pending. Fifth, dupilumab suppresses type 2 mediators in nasal polyps, but not a parallel innate myeloid axis linked to rapid recurrence, and perioperative biologic sequencing around sinus surgery remains evidence-free. And sixth, pulmonary rehabilitation improves asthma control and quality of life, but not lung function or airway inflammation. That's your roundup for this week in Allergy and Immunology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary for clinical decisions. Always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And if you have a paper you've been meaning to read, upload the PDF or paste any link at audioscholar.cc. We will turn it into audio like this one, in any of 31 languages. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.